Morning, Madam Chair, members of the committee. For the record, I'm Nancy Murphy, and I represent Hillsborough District 12, which is comprised entirely of the town of Merrimack. I'm here today as prime sponsor of HB 342 relative to lead testing for children and to ask for your support for an OTP recommendation. Before going further, I'd like to clarify one thing about the analysis that's on the bill that may be confusing or give the wrong impression. Where the analysis states that HB 342, quote, establishes a blood level testing requirement for children entering daycare and public schools. The requirement is relative really to documentation on a health form of the provision of lead poisoning and the provision of lead poisoning educational materials to parents. It's not the testing itself because that's already in statute. So it's just a little misleading when the requirement is actually just documentation, not that the testing happened. Because so it's not a new blood testing requirement as lead testing is already in statute. Um, in the interest of time and expertise and work on the previous iteration of this bill, with your permission, I'd like to ask if Dr. Jerry Knirk, former Health and Human Services Committee member, could be afforded the opportunity to use my time to properly introduce it. DHHS and other stakeholders are here to in support and will be available to answer questions as well. Thank you.
Representative, can you just
Sure.
reiterate what you said about the documentation? So,
Oh, sure.
Yeah.
The that analysis is a little
Yeah.
confusing. It looks like it's might be stating that where HB 342 will establish a new testing requirement. It does not do that. That testing requirement is already in statute.
Yep.
All it will do is change documentation
okay.
of that lead testing result on a health form, if it's available. And it will serve as a reminder to parents that may not have done that, either that they can opt out, which is their certainly their option. And it's also, it creates an opportunity for daycare providers to provide parents with an educational handout about lead testing and lead poisoning. So it's not a testing requirement, it's just documentation and the provision of information.
Okay.
Thank you.
And I'm sorry, the name of the Dr.
Dr. Knirk.
Dr. Knirk, come on up.
Yes, thank you so much. For the record, Jerry Knirk. I served as state rep for 6 years on Health and Human Services. And I think Representative Murphy has really made that quite clear. I've just handed around my testimony. This bill establishes a requirement for children entering daycare and schools to have the lead level testing documented, but that's already required. And it just gets documented on the child health assessment forms. The goal is to improve compliance with lead testing by serving as a reminder at a common point of contact with children. Just to clarify for someone who may not know a lot about this, lead is a neurotoxin that's particularly damaging to the brain during development, so it's really very dangerous to young children. And even low levels of blood lead can negatively affect a child's ability to learn and behave. And these effects can be permanent. So it's really important that we do deal with this. It's estimated about 1 in 5 cases of ADHD are related to lead poisoning. But if it's caught early, there's things that parents can do to prevent further exposure and to reduce the damage to their child's health. In addition, there's a multiplier effect because often there may be a sibling in the same home, and by catching it with one kid, you actually can not just help that one kid, but you can help 2 or 3 or even 4 kids. The most common source of lead is the lead paint in the home. Lead was not prohibited in paint until 1978. New Hampshire has the oldest housing stock in the nation, with 65% built before 1978. Now, the most common method of exposure is the lead dust. The lead dust comes primarily from friction when you're opening, for example, painted lead windows or doors, and the dust gets on the floor, then on the toys and the pacifiers, on the fingers, and anybody that's had kids knows that everything goes in the mouth, particularly when they're very little. So lead levels also can be higher in the soil drip zone, in the soil around the drip zone of the house due to leaching of lead from the house. Also adjacent to roads from old lead and gasoline. It persists in the soil for a long time, and also lead in pipes as well. So SB 247, which was passed in 2018 with Senator Bradley as a co-sponsor, established the requirement for lead testing in children by ages 1 and 2 in order to identify children who have been poisoned and therefore identify safe housing so that work can be done to remediate that. But compliance for that requirement has been low. Testing peaked in 2019 prior to the pandemic, but still only 64% of 1-year-olds and 75% of 2-year-olds had been tested. By 2021, secondary to decreased visits during COVID and also some testing supply problems, the testing dropped by 20% down to 51% and 60% respectively for the two ages. States that have implemented a documentation requirement for entry into school or childcare have seen increased compliance. Maryland got 61% increased compliance. Now, in order that a child not be kept out of school or that a parent would not lose a valuable daycare slot, the bill, as introduced, established a provision to grant a 6-month grace period to remedy the deficiency. But the child care agencies over in the House, the child care agencies rightfully rejected this. They objected because the parent's failure to comply would leave the child care facility out of compliance with licensing. And that lack of compliance is public information under RSA 170E10:2, Roman 2. And that's posted on the department's website for review by members of the public. So that's a little bit of a problem. The sponsor agreed that this would be unfair for the child care agencies to have negative published findings for the failure of the parents to follow the law. So the amended version alters the language so that for both schools and child care agencies, their only responsibilities are to notify the parent or guardian that unless the child is exempted under RSA 130A5C, blood level testing is required in the state, and to distribute written and education or electronic educational testing materials, educational materials provided by DHHS on the dangers of lead poisoning and the importance of both lead level testing in children and why it should be done and how it can be done. The amendment also limited the population to just ages 1 to 6 because that's really our target. It's not that it's not a problem older, even in adults, but it's much less of an issue in the kids, little kids. But again, parents have the right to exempt their child from testing under RSA 130A5C. HB 342 does not interfere with their ability to exempt the child and exercise that right. Exemption of testing also, furthermore, does not serve as a barrier to being admitted to school or to daycare. The burden that this bill will place on child care agencies and schools will be really extremely small. Schools and child care facilities also already have to maintain a health form on each child, which documents the immunization status. And the New Hampshire Early Childhood Health Form, which many schools already use, already has a place to document lead level testings on that form. So this is not something that's going to be really tricky. So as a result, the documentation should be rather easily achieved. And if the school catches even just one kid who can then be treated and prevent a learning disability, they'll save much more on their special education costs than they've ever spent in compliance for the whole school. Now, during the debate in the House floor, those in opposition to this bill claimed that the passage of the bill would cause many families to lose housing. But that's not true. The parameters for investigation of the housing of children with elevated blood lead level testing was very carefully crafted in SB 247 in 2018, thanks to Dan Feltus and Jeb Bradley, in order to prevent that occurrence. There are very specific laws about you can't be evicted, and actually there's also funds to help landlords with remediation. And so you can't just throw people out in the street because they test positive. So in summary, the goal of this bill is to improve compliance with blood lead level testing of our children when they're very young, to allow early intervention and identify unsafe housing. It does not create a new requirement. It simply is a point of contact reminder for parents and guardians to get it done and get the lead out. I'd be happy to take any questions if you have any.
I do have a question. What happens with, can you go through the process of when a child goes into the daycare, first time, and the parents don't provide the lead testing? What happened? I mean, can you walk through the process?
Well, in the original bill, they were given 6 months to comply.
Right.
The current, they will simply be told it is the law to have the child tested unless they're exempted, unless the parents have chosen to exempt the child. That's one. And number two, they'll receive either written or electronic information, because this information already exists from DHHS, educating them as to the hazards of lead, the problems of lead exposure, why their child should be tested, how to get tested. So they are basically educated. So this again becomes a point of contact education experience, not really an onerous burden.
Okay. And that also goes, if someone doesn't go to daycare, but they go right into school, same process?
Yes, exactly. And that's the point, that some kids may be going into, and the reason for the 1 to 6 is, again, someone may go into daycare very early before the requirement is in place,
Right.
because it's required at 1 and 2. And so you don't want to have to, struggle with that issue. But yes, some kids don't go to daycare, but then when they show up for kindergarten, the same type of thing would occur. They would be reminded. It's a little late. You kind of like to catch them before that time, but it's better than nothing, because you can still, they're still growing their brains. We're still growing for quite a while, actually. My wife insists that that's still happening. But anyway, so it's still something that can be very helpful at that age 5. And again, it also may help their younger sibs who don't know. And some parents simply don't take their child to the doctor, or they don't take them very often. They don't have a PCP. That's a real problem, but it's a reality in this state.
Okay, thank you.
Sure thing.
Any questions? Seeing none, thank you, Doctor.
Thank you.
Representative Rung?
Oops. Thank you very much. For the record, my name is Rosemary Rung. I'm representative for Hillsborough 12, which is the town of Merrimack. I'm strongly supportive of this bill, and I want to just touch upon one thing that Dr. Knurk mentioned. In his background, I served on the Merrimack School Board for nearly 9 years, and looking through our school district budget this year, and the state budget as well, as the state and local districts spend millions and millions of dollars on special education. And even though the health and the cognitive health of children is of paramount importance, I think this bill will help inform school districts and child care centers on interventions that they can do to address some of the cognitive impairment that occurs because of lead poisoning, and be able to manage that better. We know through many other early childhood learning strategies that early intervention when there is mental or cognitive impairment works. And it enables a child to reach a much greater potential than they would otherwise. So having schools to have this information, knowing what children have experienced lead poisoning, will help them be able to address that child's needs sooner than later, and will have a better outcome. So that's all I have to say. If you have any questions, I'd be glad to answer them.
Senator Bradley?
Good morning. I apologize. Apparently, I can't get on the General Court website right now. So could you just outline what happened, the vote, and what the process was on the floor?
Oh, I'm going to defer to the prime sponsor on that. Nancy, do you know what the vote was?
Senator Bradley, I have it right here.
Oh,
It passed on a
Looks like a
voice,
voice
on
vote.
a division vote. 193 to 80 on a division vote.
All right.
And And the amendment was brought into, was it a floor amendment? Right,
No, the amendment went in through committee.
okay, all right. Thank you.
Okay.
11-9 vote in the House Committee and 193 and 184.
Any other questions? Seeing none,
Okay, thank you.
Thank you, Madam Chair and honorable committee members of Health and Human Services. I will say that Dr. Jerry Knirk, the Honorable Dr. Jerry Knirk, did a very good job of explaining exactly what the crisis is that we have here in New Hampshire and probably other states as well. Lead is a serious issue. I'm not going to, I'm not here to say otherwise. However, I don't think that we actually approach this in the right direction. Testing is good because we can catch them, catch the kids at an early age, and we can address the issue when they're still young, and before the things such as ADHD start to develop. And with proper nutrition, it's been proven that we can reverse the poisoning that has taken place. What I think we do by asking to do more testing, which I don't think this bill's really saying to do that, but it might do that unintentionally. I know you all received one of these. If you go to, well, right on the first page, you'll see that testing increased until 2019. And then on the next page, you'll see that actually it's the bottom bar chart. You can see that blood levels were actually on the decrease before COVID. During COVID, we stopped testing as much for whatever reason, and that is that's something that needs we need to get the testing back into place. Having people report this at a child care center or the primary school, especially when not all kids are actually living in lead infiltrated houses, because not all houses were built before 1978. And also because the parents can opt out, or actually the way I read the law, it says opt in. And having this in law to actually require the parent to fix it within 6 months, the testing that is, having their child tested within 6 months, I'm not sure that necessarily fixes the problem. At any rate, going forward, this has kind of motivated me because it is a serious issue, and testing addresses something that's already happened. Next year, and over the next few months, I'm going to be working on ways that we can actually help landlords get the lead out of their buildings before poisoning occurs. And then I think this is really the safest way to go at things. And there are such things that I've put in my report. There's what they call RRP technology, which stands for Renovate, Repair, and Paint. And we need to make that technology more available to the landlords. I also think we need to incentivize our landlords to actually do this before they have children with families or families with children under the age of 6. And we also need to look at grants. A lot of these grants are not really all that attractive to landlords because of all the stipulations that go along with that. And so I would like to look at the grant nature and how we can actually incentivize our landlords to actually do the right thing. So that's pretty much where my testimony is. I would ask that you would find this bill inexpedient to legislate, and that we would work on a bill next year that would actually work at being a more proactive solution. So in summary, I don't disagree with anything that's been said so far, with the exception of in Nashua, we do have a constituent that is now looking for an apartment because her income level is too high, doesn't fit the grant requirement for the landlord. So the landlord had found a loophole in the law someplace, and I don't have that one, but I can find out what it is. And that landlord has now asked her to find more different housing because he's going to be shutting the apartment down, abating it, and then he will not be able to rent to her because she's too high income. So there are situations out there, probably not many, but there are situations out there that are causing people to have disrupted housing. That's it. I'll take any questions.
Thank you, Representative. Any questions from the committee? Seeing none. Thank you.
Thank you.
Michelle Roberge from DHHS.
Thank you. Would it be okay with, to the committee if I have Beverly Druin? Also
Absolutely.
come
2
up
for
as
1. I like it.
well? Good morning, members of the committee. For the record, my name is Michelle Roberge, and I'm the administrator for the Bureau of Public Health Protection within the New Hampshire Department of Health and Human Services Division of Public Health Services. With me today is Beverly Druin, who is the division's Healthy Homes and Environment Section Administrator, and we're here to provide information relative to HB 342. The department would like to thank the sponsors of this bill for their interest in supporting our vulnerable populations, and we are pleased to collaborate with the prime sponsor, Representative Murphy, and other public health, child care, and education advocates to improve the lead testing rates while reducing impacts to schools and child care facilities. Blood lead testing is critically important to ensure the health of children in New Hampshire, as the only way to know if a child is poisoned by lead is through blood lead testing. Any amount of lead in a child's body is dangerous and can cause health, cognitive impairment, and behavioral problems. These health effects are more harmful, as you heard earlier from Dr. Kernark, to young children because their bodies are still developing and growing. Young children often put their hands in other objects, toys, which may be contaminated with lead in their mouths, so they're more likely to have a direct impact with lead than with older children. By testing at ages 1 and 2, parents and healthcare providers can learn if mitigation strategies are needed to reduce further exposure prior to negative health effects. And I'll also add that it may reduce potential costs associated with special education further down the road. Under state law, all children in New Hampshire are required to have a blood lead level test at ages 1 and 2. The department also recommends blood lead testing for children ages 3 through 6 who have not had those tests at 1 and 2. According to the Centers for Disease Control and Prevention, similar testing requirements exist for all children enrolled in Medicaid, and the American Academy of Pediatrics recommends that providers test asymptomatic children for elevated blood lead concentrations according to the federal, state, and local requirements. As noted in the department's most recent lead exposure data brief, which you all should have a copy of, in 2021, 5,360 fewer children were tested, had their blood lead levels tested since 2019. This was largely due to the COVID-19 pandemic and a nationwide recall of in-office blood lead testing supplies. So those in-office testing machines that can take a finger prick and test a child's blood, there was issues with the testing supply kits, supply issues. This represented a 25% drop in the number of children tested in New Hampshire for blood lead levels since 2019. Efforts such as HB 342 are critical to help increase awareness of the dangers of lead poisoning and the importance of lead testing. And I think we heard Dr. Knurk say, and I'm just going to refer to it, it's sort of a point of contact education opportunity. So for the schools or the nurses or the administrative staff to just, again, provide the educational materials that we will provide to the schools and daycares to get the word out on the importance of lead testing. And I would just like to add a note. Similar efforts have been already established in the city of Claremont. The Claremont School Board instituted a policy in 2017 that required both the 1 and 2-year-old blood lead level tests be documented on the physical examination form for entry into pre-K and kindergarten. And with that, I would be happy to take any questions if the committee has any.
Any questions from the committee? Senator Bradley.
Good morning. Thank you very much. Would you care to comment on the prior speaker who indicated different approaches are necessary and what your thoughts are?
Sure, certainly this issue is a very large issue, as you know, Senator Bradley, and I think there are multiple efforts that need to be incorporated to address this issue. And I think I heard the previous speaker talk about funding or support for remediation. Primary prevention or remediation is the most valuable. It's a valuable tool. We want to prevent those kids from getting poisoned in the first place. So it's critically important to get funding out there. And I would like to note that there was a bill, I believe it was last session, that added $3 million to, and Beverly, you can help me, is it the HUD?
The New Hampshire Housing Finance Authority Low Interest Loan Program. Just got refunded.
Right. So that's also the department, is in support of that as well, because again, it's a multifaceted approach. You need to get the word out about getting those kiddos tested and then early intervention services as quickly as we can. And we need to do preventative services to get the lead out of homes in the first place to prevent them from getting poisoned. So I would agree that it's a multifaceted approach, but this bill is a good opportunity for that point of contact education when, with kiddos that are in that age category.
And I guess the conclusion, thank you, Madam Chair, that I come to is the two are not mutually exclusive by any means.
Right.
That the strategy in House Bill 342 of interacting with parents that haven't tested their kids as well as remediation go hand in hand.
Correct.
Okay, thank you.
Any other questions from the committee? See none? Thank you.
Thank
both.
you.
Henry? Welcome.
Thank you, Madam Chair and members of the committee. For the record, my name is Henry Vayu, and I'm here on behalf of the New Hampshire YMCAs. The YMCAs are one of the state's largest child care providers. Locations in Manchester, Concord, Nashua, Keene, and many satellite locations around the state. So I'm coming from the perspective of the child care providers. And we support this bill. We're happy to be a partner in trying to get more kids tested. The burden is really minimal. So right now, the form that a parent has to fill out for the child when entering a program already has a line on there about the lead testing. Right now, when the testing isn't done, that is just left blank. All this bill will do is, if the parent hasn't filled it in, we'll ask them if they've had it done, and if they hadn't, then we'll just give them the information. So we're just we're an important point of contact with the parent, and it's just a reminder. And we're just hoping that that extra reminder will increase the testing. Over COVID, it went down a bit, and so we're hoping to bounce it back up. And Senator Bradley, to your question about the previous testimony, these bills aren't exclusive. You can do both. This is sort of a baby step, sort of trying to get the testing up. The stuff that was suggested is probably a separate bill that's much more comprehensive, but I wouldn't hold this bill back to do something like that. And I want to thank the chair for scheduling us at 9 o'clock, because I'm heading down to the Red Sox at 1:30. So.
Any questions from the committee? I just have one.
Yeah.
Just to make sure that the brochures that the daycare providers in the schools are going to be handing out are going to be provided by HHS and not at the cost of the schools or the daycare providers.
We're not producing anything.
Got
We're
it.
handing them off.
Thank you. All right. With that, thank you.
Thank you, Madam Chair. And members of the committee, for the record, my name is Andrew Hosmer. I'm here today on behalf of the New Hampshire Public Health Association, and we are in strong support of this bill. As you may know, New Hampshire Public Health Association is a statewide nonprofit public health membership association founded in 1990. We represent over 250 public health organizations and professionals in New Hampshire. Their mission is to champion public health policy and practice, promote health equity, enrich the workforce, and inspire others to improve the public's health. Without repeating what Dr. Knirk so eloquently testified to, we look at this bill not as a mandate, but certainly as an augment to the statutes that are already in place, specifically RSA 130:A-5. It is an opportunity for improved awareness with lead testing. It is a gentle reminder to parents and guardians that this is a very serious issue, that lead is poisonous, has long-term impacts on children, and we can improve outcomes in addressing these cases by the earliest intervention as possible. We also view the goal of lead testing is certainly to get lead poisoning down to zero. So a multi-pronged approach, whether it be with remediation and education, and anything else that is works in conjunction with those two prongs, would certainly be supported. So I ask you to strongly support this bill as written, and happy to take any questions.
Any questions from the committee? Seeing none. Thank you.
Thank you, Madam Chair.
Is there anyone here that would like to speak on House Bill 342 but was not given the opportunity? With that, I will close the hearing. And when Cam is ready, we will, and again, I will not be executing any bills today, so. I will open the hearing on House Bill 613 FN relative to regulation of individual health insurance market under RSA 404-G. And I recognize Senator Bradley to,
Unless there's a House member who's prepared to introduce it.
you can do it from there. If you want.
Thank you, Madam Chair. For the record, Jeb Bradley, Senate District 3, and one of the co-sponsors of House Bill 613. This bill was a request of the Insurance Department. It passed the House on the consent calendar after a 19-0 vote in the Commerce Committee. The reason for this bill is that the individual insurance market, which is governed by RSA 404G, has created over the years a not-for-profit entity which has the authority to assess healthcare carriers in order to promote greater access to the individual market. So there've been a number of amendments in 404G that have helped to support the individual market. There was a risk study mechanism, then the high risk pool, a federally supported high risk pool, and then more recently the reinsurance mechanism. If you recall the discussion about Medicaid expansion, the New Hampshire Health Plan was created to create a matching requirement for Medicaid expansion and some of the funding for the state share. So the request of the Insurance Department is to update this statute for all the changes that have been made. Alex Veldwevel can probably do a better job than I in going through all of those things. The department has asked me to introduce amendment 1279, which, given the changes that are proposed in the Medicaid expansion reauthorization legislation, aligns this bill with Senate Bill 263. So, Madam Chair. Uh-oh.
We don't have the amendment.
Uh-oh. Well, I hope you have it, Alex. Rescued. My fault, Cam, for not having Marie send it to you. Apologies to the committee. So on that embarrassing note, I'll conclude my testimony.
Didn't mean to call you out there, Senator.
That's all
Any
good.
questions
You
from
should
the
be
committee?
calling me out on that.
The only question I have is, based on what the, it's a fiscal, it's an FN, but it says, the insurance department states that this bill has no fiscal impact on state, county, and local expenditures. Why would it be an FN?
So I am, when a bill gets introduced, I'm learning this too, as now a new member of finance, whether it's the agency or the LBA makes a determination whether a fiscal note is required, even with, without an appropriation. So it's a status that's put on a lot of bills. Doesn't necessarily have a fiscal impact, but it does trigger that report from the agency back to the LBA as to what the fiscal impact may or may not be. That's why.
Thank you. Any questions from the committee? All right, Alex. Sure.
Join.
Another two for, I like it. Welcome.
Thank you. We'll have Heather explain the original bill and I'll explain the amendment.
Good morning. I'm Heather Silverstein. I'm General Counsel of the New Hampshire Insurance Department. Senator Bradley did a great job of introducing the original bill as we had submitted in the House. This has been a long time coming. You know, this is a bill that with 404G in the individual market, you know, one program gets added and then another program gets added and it keeps on getting amended. And then, you know, I used to work for judges. I used to be a judicial clerk. You look at a statute and then you have all these amendments with different programs and then it starts to not really make sense anymore. You're wondering why they're still using these terms that are outdated, the, you know, high risk pool, it's not even needed anymore. You know, and I look at it clearly from like, you know, what would a court think of this bill looking at it? You know, over time, you understand why it happened, but it just comes to a point where it needs to be revised and bring it up to the current state. And so so that kind of background has happened at the insurance department every time we've kind of looked at the bill and applied the bill, whether it's with the 1332 waiver in the reinsurance program, which helps support the individual market, or with regard to Medicaid expansion and how that is funded. So that's kind of the history behind it. We needed to sync up some of the definitions to be, you know, consistent with these other programs as well and get everything up to date. And then obviously there's always typographical once you start renumbering and whatnot. So that's really what we're trying to do. And we worked with the New Hampshire Health Plan as well in making the changes that we did because we wanted them on board. Obviously that has to work out practically, you know, as it's applied. And so we wanted them on board and they assisted us. And then I'll turn it over to Alex because really the amendment is about syncing up our bill with Medicaid expansion, and he fixed another typo that was missed. So, okay.
Okay, thank you, Heather. I'd like to just start with a brief, very high-level overview of what 404G is all about, and then I'll go to the amendment. The individual market is inherently a less stable market than the employer-based coverage that is offered to the small group market and the large group market. And the reason that is that it's easier for the individual market to get overloaded with people with higher healthcare risks and therefore higher healthcare costs. With the group market, you're getting enrollees who are brought together for a purpose other than insurance. They're brought together because they work for a particular employer. So that inherently spreads risk out and makes those markets more stable. So the individual market, there's a bunch of people who are in the market because they're choosing health insurance. So they're inherently more likely to be a higher risk. And then it's also traditionally been a smaller market. So it has difficulty sufficiently spreading its risk. That's why in the 90s, this 404G was passed, and it set up this entity, a nonprofit public instrumentality called the New Hampshire Health Plan, which has a board of directors, and the ability to assess all coverage to support the individual market. And then with the passage of time, we've had different mechanisms, and now we're sort of cleaning up to reflect what the current support mechanism is, which is the reinsurance pool, and the other function that the New Hampshire Health Plan serves, which is to provide part of the state share for Medicaid expansion or the Granted Advantage program. So, and that last piece is important because we recently noticed as our bill is moving forward and we're looking at Senate Bill 263, the reauthorization bill, we noticed that bill made an amendment to a part of 404G, a key amendment, which is determining how much of the assessment goes to fund the Medicaid reauthorization. It is amending a provision that we eliminate in our bill, in our cleanup. So that doesn't work very well. So what this amendment before you does is to recreate that section in 404G and to word it in exactly the same way that Senate Bill 263 words the amendment to that section. I conferred with Legislative Services and they agreed with me that if we amend it this way, that will fix the problem, that the language will come out right whichever bill passes first, because they both say the same thing. So that's why we need the amendment to harmonize this bill, the rewrite, with the Medicaid reauthorization bill.
Thank you. Any questions from the committee? Senator Bradley.
I would note, and I probably should have mentioned this when I testified, that when you look at the history of the individual market, the steps that have been taken, especially moving Medicaid expansion into a managed care option, has stabilized the individual market along with the assessment and the mechanisms in place so that according to the Urban Institute, the average typical 40-year-old non-smoker, we have the lowest individual insurance rates in the country. So
Yes, we've been very successful.
that's a good thing.
Yes, we're proud of that.
The only question I have, I know you amended it to mimic the language in Senate Bill 263. And you said that both the House version and the Senate version have the identical language?
Yes.
And the language that's in there, in statute already? So
It's,
I'm just a little nervous that we're putting the cart before the horse before Senate Bill 263 has passed, as well as the House bill. But is that language already in the current RSA for Medicaid expansion?
Yeah, that same language is in the current Medicaid expansion bill. Now, the current statutory provision of 404G that relates to the Medicaid expansion is worded a little bit differently. It refers to some liquor commission funding in a certain way, and what Senate Bill 263 does is change that language to reflect that the money coming through the liquor commission is happening differently going forward.
Okay,
So we have that language reflected.
okay. Thank you. Any other questions? Seeing none, thank you.
Thanks.
Michael Degnan? Welcome.
Senator, thank you very much. I'm Mike Degnan. I'm the Executive Director of the New Hampshire Health Plan, and I've been running the organization since 2007. And I've had the pleasure of running the high-risk pool, the federal high-risk pool, the outreach and education program for the ACA. We did the collection for the New Hampshire Health Protection Program, now doing the assessment collection for the Granted Advantage, and in the last couple of years running the reinsurance program. So back last fall, the team from the insurance department asked us if we would work with them to help rewrite and get 404G current with the operation we have now, and we did do that, and we're here to say we fully support the modifications to 404G that are being suggested in this bill, and look forward to continue to work with them. We have a very detailed work plan of operations that's posted on our website, nhhp.org, that outlines what we do in detail, and this is consistent with that. So we really welcome this modification. So thank you very much.
Thank you. Any questions from the committee? Seeing none, thank you.
Thank you very much for your time.
Michael was our last speaker. Is there anyone here that would like to speak on House Bill 615 FN? With that, I will close the hearing. And wrong listed. We will have a 5-minute break recess. Thank you. I'm going to start the hearing on House Bill 642 relative to wait list registry and budget flexibility for services for the developmentally disabled. And I invite the prime sponsor, Representative Stringham. Welcome.
Thank you, Chairwoman Birdsell and fellow and committee members and guests. I'm Jerry Stringham. I'm the state rep from Lincoln, Woodstock, and Easton. I serve in the House Finance Committee Division 3, which is Health and Human Services. And I'm pleased to introduce House Bill 642 as amended. As you mentioned, it's titled An Act Relative to the Waitlist Registry and Budget Flexibility for Services for the Developmentally Disabled. Area agencies are private nonprofit corporations funded in large part and supervised by the New Hampshire Department of Health and Human Services Bureau of Developmental Services. Area agencies provide programs and services for people with developmental disabilities and their families. The focus of HB2 is to provide the ability for area agencies to request a reasonable cost of living adjustment to an individual's budget for budgets over 2 years old. Under the current system, if an individual comes off the wait list and has consistent needs and life circumstances, there's no mechanism to raise the budget to the current labor and inflation realities. This puts both service providers and individuals who receive support at risk. The second issue is that because of shortages of workers, only about 60% of the budgeted positions are currently filled. The remainder of the budget and available funds are not being expended as they're being allocated for services that can't be met. As amended, this bill would allow DHHS the flexibility to reallocate the existing unused budget to either raise salaries for existing workers and filling some more of the empty positions. The adjustments are intended to be available based on need to both new service recipients and those with budgets over 24 months old. So these older budgets we call legacy budgets. Finally, this provision, when amended, will be repealed on July 1st, 2027, by which time the Health and Human Services Subcommittee felt that this new delivery system would be in place and needed adjustments could be included in the budget process. HB 642 passed the Health and Human Services Subcommittee unanimously with a vote of 20-0, and then passed the full House on the consent calendar. I do have one note that there appears to be a typo in the amended language where it says Section 2 prospective repeal RSA 172-A. It should be repeal RSA 171-A, I believe. So with that, I turn the bill over to you, and I'm happy to answer any questions, but there's a lot of people here too who can shed some light on the importance of this bill.
Thank you, Representative. Any questions from the committee? Seeing none. Thank you.
Thank you.
Melissa Nemeth. Welcome.
Good morning, Madam Chair, members of the committee. My name is Melissa Nemeth. I'm the legislative liaison for the Bureau of Developmental Services. The department is opposed to the bill as it's been introduced and amended through the House. So I'd like to just point out some of the concerns that we have. Currently, there is a lot of work being done, and Representative Stringham alluded to that, talking about systems work being done by the Bureau of Developmental Services. There is a whole host of work initiatives being taken on right now by the department, mostly through the contractor Alvarez and Marsal, and you may have heard of some of this in some other contexts, who had given some recommendations to the department to make some changes. One of those changes is changes to the rate structure. The rates are very old, the current system that we have. So we have actually engaged another contractor, Myers and Stauffer, who is doing a great deal of work with the department. They have received cost reports, and they're trying to build up rates that are commensurate with the delivery of service. So the department does not disagree that the wages paid to folks and the budgets that are used for individuals, there should be the cost and payment for that should be commensurate with what the costs are to provide that service. However, the difficulty is we're in a place right now where this is a solution that is being worked on. In fact, the rate redesign is expected to be piloted at the end of this year. So it feels premature to make other adjustments at this point. Part of the purpose of the rate design also is to ensure that rates are fair and equitable across the state and are specific to the service being delivered rather than based on the being provider specific like they are today. For example, in today's system, if an area agency puts out requests for proposals for services to be delivered for an individual, they get responses to those proposals. And even though it's the same service to be provided to an individual, they would get budgets back from different vendors with a different price to provide that service. So part of the goal of the rate redesign is to bring equity to the service delivery system and ensure everyone is getting what they need. Additionally, once these rates are, they go through the pilot and they are rolled out statewide and implemented statewide, the state is going to be looking at costs on a regular basis. The state does not know yet what that frequency will be, whether it would be, for example, annually or, every few years. But the goal is that these are going to be reviewed on an ongoing basis, and what they're going to be reviewing is what are the costs. There is inflation, there are labor rates that change. So ensuring that these are constantly being looked at and rates can be readjusted as appropriate to ensure that these budgets are not, left stagnant, but that these elements can be taken into consideration. As Representative Stringham indicated, these have been so-called legacy budgets, and he pointed out under today's system that if there's no mechanism to ask for an increase in the budget if there are costs of living adjustments. Increases to budgets would only be approved if the needs of the individual changed. And part of the reason for that is actually in a current administrative rule, HEM 503.13, paragraph G. That is what prohibits in today's world the increases to these budgets if there is not a change in the individual's needs. Another concern that the department has is that, and I know Representative Stringham mentioned that there could be some flexibility in what the department can approve, and that there may be some unused funds. The problem is when the department asks for the allocation pursuant to the statute, it is requested based on the information we have at the time. So to maintain the budgets that we have and also projections for people that will be coming into services. So there could be an unintended consequence here that if there are funds that are now put into these budgets to increase them that were not anticipated, if that takes too many of the funds that are already allocated, it could potentially create a situation where people that are new trying to come into service may be in a waitlist situation in case if there were funds, all the funds had been expended. And I note that Representative Stringham did indicate this would, give flexibility, but it does point out, looking at lines 5 into line 6 of the bill as amended, that the department shall use existing appropriations. So it doesn't seem to give a lot of flexibility in the way that that language is written. Also, as written, it just refers to the department using existing budget appropriations, not specific to the Bureau of Developmental Services and the budgets for those services. So presumably this could be read to mean the entire department. So say, for example, if DCYF. It's not specific in here, which, and that may have been unintentional in the drafting, but I did want to point that out that the department had noticed that as well. And it talks about negotiating reasonable wages and appropriate budgets with area agencies and service providers. Today, as I mentioned, and this will change going forward, where the system I mentioned of the area agencies sending out requests for proposals, that's going to be going away through the system redesign as well, where an individual can select a provider. But in today's system, as we sit, any negotiation on the budget is done between the area agency and the provider. The department does not get into those negotiations. The department receives a budget that is approved by the area agency based on what they get from the vendor. So the department does not negotiate right now directly with service providers. It's only with the area agencies. And there was a previous language in here that was taken out regarding not putting in a salary cap for providers because one does not exist. But in hearing Representative Stringham's introduction, my sense is that there is still in here a notion that the department somehow sets the rates that are paid to a direct support provider. And I just wanted to point out that the department does not do that. While that may be in the budget that the department approves, the department does not have the contract with the direct service provider. So, and in fact, the department doesn't know how much of that budget that is, when it comes in the budget, it says this is the salary for the direct support provider. What the department does not know is when those services are billed for, what that check to that direct support provider looks like. So we do not have a sense of the payment, and we don't set the rate that goes to providers. And with that, I'd be happy to take any questions.
Any questions from the committee? Senator Bradley.
Thank you very much. Good morning. So hasn't this line in the budget had a pretty substantial lapse because services are not being whether it's inavailability of providers. As I recall, I don't have my folders here in front of me, but I think there's been a pretty big lapse.
I do not know details of that either, Senator Bradley. I would be happy to get that information to the committee. My understanding is, that from time to time, there are funds that are unspent, but to the extent of which that would be, I don't know.
But if that's the case, then wouldn't this provision, especially in combination with, what the Senate has passed in Senate Bill 86, what the House Finance Committee is contemplating in House Bill 2 for Medicaid rate increases for the disability community, why is this not appropriate at this point in time to proceed with, to try to make sure those services are available to families that need them?
So, the department's position is that with the rate increases that are going to be coming, it's premature to do this. And it could be, now, this is all unknown, but it could be a situation where if, say, a new rate is negotiated now or a budget is increased and whatever is established there, once these rates roll out, we don't know what the ultimate rate for that service is going to be, which might be different, more or less than what would be in any amendment now. So the department feels like it's because of the proximity in time of when this rate restructure is going to be happening, that it doesn't really make a lot of sense to do this at this point in time.
Okay, thank you.
Senator Whitley.
Thank you, Madam Chair. Just sort of following up on that, I understand, the position that it may be premature because of that work, but I actually don't see it as inconsistent. So I'm wondering if you could explain why you believe that this would be inconsistent with that work.
I guess the department's position would be that because we don't know where as I just said, we don't know where those rates are going to land and what is going to happen with these budgets. There's a risk of, this budget changing and then, who knows what it would be in the future, and what if the rate were to go down versus, if the department were to approve an increase in a budget now, and the service rate that ultimately comes out of all this rate work is a lower rate than what was approved in this budget, then that could be problematic as well. So the department just feels like that we are so close to a long-term solution that it doesn't really make sense to do something right now for in the short term. And also with the repeal being not until 2027 of this, the rates will be implemented by that time. And then this would be in addition to that. And again, that seems to be inconsistent. As I mentioned, the department's plan is to ensure that rates and budgets are being reviewed on a regular basis. So that seems to be inconsistent with what is going to be happening in the rate redesign as well.
Follow-up? You had mentioned that it could be that the rates are going down, but everything that we have heard in this committee across the healthcare, across the board is that providers, the rates are very low. And that's why we are losing our healthcare workforce. That's why we're losing providers. So I don't know what the basis is to say that. Well, what is the basis to say that it's potential that the rates would go down to providers?
So I guess that is just it's a potential that could happen. Do we have a sense of how likely that is? I would say no. The rates are increasing, but because we don't know the exact cost of how all this rate work is going to roll out and what the ultimate cost, say for like each individual service, what that would be. I think that's where there are unknowns, and there could be, fluctuations within the budget. So it just didn't seem to make sense to the department to do something on a short-term basis when there's a long-term solution coming.
Thank you. I do have a question. When do you think, when did you say that redesign or the changes are going to be launched?
So the department is right now targeting beginning to pilot these rates in December of this year.
Thank you. Any other questions from the committee? Senator Prentice.
Thank you, Chair Birdsall. This is kind of a follow-up on what Senator Birdsall's question. So this is what you have as a targeted date for the end of the year, but it's not a guarantee.
No, we're working with a contractor, and so all of these pieces are being worked out. I would say, that was the date that I was given, that the department is looking for to begin piloting these rates. Could it be off by a month or so potentially? But it's not going to. I don't see that it would be delayed for a lengthy period of time. The department feels like the December 23rd December 2023 is the target that we can share and is really achievable.
Follow-up. Given all the concerns that you've brought forward and looking at the work in the House and the votes in the House, have you spoken with Representative Stringham? Have you tried to work this out?
Not recently. We had spoken early on in the process, but not more recently, no.
Okay. I would suggest that.
Thank you.
Any other questions from the committee? Seeing none, thank you, Melissa. Rebecca Bryant. Welcome. Sure.
Good morning. Thank you. Thank you for allowing us the opportunity to speak in favor of House Bill 642. As the current CEO of Lakes Region Community Services, the designated area agency for Region 3, and having served as the CFO for over 10 years prior to my current position, I wholeheartedly support this bill, which brings to light one of the root causes of our inability to retain and recruit direct care workers. As you well know, there's two sides to a budget, the revenue side and the expense side. And you're very accustomed to us as Medicaid providers asking for a rate increase. But in this situation, we are asking within current reimbursement rates for the ability to adjust expenses, actual expenses necessary to provide services. For many years, two factors have tied our hands and effectively capped DSP wages. One was the literal capping within the budget template of the Excel cell in which we entered the DSP wage, a practice that has only been corrected in the last 2 years. Recognizing that BDS has stopped this practice, the families I represent remain concerned that without specific language preventing a future BDS from enacting a cap, that practice is not buried. BDS reviews and approves every single budget for an individual receiving waivered services down to a line item in the budget, from a $500 advertising expense to a $100,000 personnel expense. BDS questions and vetoes or approves at a line item level. Paying a DSP above the acceptable norm of the day, in BDS's opinion, requires substantial conversation and emails to defend the wage, explain the need, etc. Paying above the norm, which is currently questioned at anything above $20 per hour for a DSP, but until recently was $16 an hour for many years, is treated as an exception. And if a higher wage is approved, it is at one budget at a time. This is BDS controlling wages. The other was the administrative rule for adding individuals to the waiting list. In HEM 503.13, allocation of funds, Section G, it states, in completing the waitlist registry, the area agency shall exclude those circumstances where funds might be needed to cover additional expenditures, such as cost of living or other wage and compensation increases. Once an individual budget is approved by BDS, the only way to ever increase that budget is by placing the individual on the wait list. By precluding the ability to place an individual on the wait list for wage increases, we have created 30+ years of legacy budgets and kept both families and agencies from being competitive employers. We are operating at a time, and I believe as Senator Whitley referred to, when New Hampshire's agencies and provider agencies are experiencing an unprecedented workforce challenge. I've included in my written submission the latest CS&I report on the workforce. I personally have received threats multiple times over the past 18 months from providers demanding a budget increase for an individual in order to attract and retain employees at a higher wage. I'm forced to ask those providers to come up with some reason other than a wage increase for the budget increase, requiring some creative writing and bordering on Medicaid fraud. Recently, an individual in my region attempted to transfer to a new vendor provider that will allow the services to be conflict-free. Taking their legacy budget and comparing it to the budget presented by the vendor presented a 4 times increase in the funding required due to staffing costs. This issue is going to take off to a whole new level as I force 150 individuals to vendors in my region to remain conflict-free under New Hampshire's Corrective Action Plan. It is time to end legacy budgets. This morning, you're going to hear a couple other things. There's concern over the term waitlist in this legislation, and whether I'll leave that to the legal folks as far as waitlist in the law versus waitlist in the reg. At the area agency level, we do operate under 503, which does use the waitlist terminology and prohibits us from adding folks to the waitlist for increased costs. You're hearing a lot of talk about rate increases coming and maybe rate decreases, which, by the way, will just put us out of business and put our folks on the streets. But with the new rates being developed, you keep hearing that they're based on need. And this is getting a little in the weeds, but we have something that the Bureau is working with A&M called the Supports Intensity Scale. And the Supports Intensity Scale is how they plan on tying the needs of the individual to the rates being developed. And that's a whole nother conversation. We have tremendous concerns over that. But what the supports intensity scale doesn't take into account is the lack of people to provide the supports. You also heard reference to the fact that providers are not all the same. This is going to put us all on the same playing field and level it, and we hear equitable and fair in regards to our services. I can tell you that one of the reasons that we pay differently in 10 different regions is because we're 10 different private nonprofits working with vendors across the state. My needs in Laconia and in Plymouth and in the North Country and my geographic area demands a different wage than maybe it does in Nashua. My accessibility to workforce is very different than Gateway's accessibility down on the border, who's also competing with Massachusetts. So yes, our rates are different, and there is no guarantee that a DSP is going to be paid the same in every single vendor in every single region, but that's because we're not the same. And that is how our system was created, to respond to needs at the local level in our communities. I'd be happy to answer any questions regarding all of this.
Thank you. Any questions, Senator Prentice?
Thank you, Chair Birdsell, and thank you, Ms. Bryan, for coming this morning. I think you already touched on this, but I just want to maybe dig a little bit deeper. So there was the conversation about rates and rate studies and adjustments being made in the future, and they may go up and they may go down. How would that, if this were to be enacted and this, moved forward, and then a rate study came back and suggested that, suggested or recommended that the rates would say go down? I think you said that would just put everybody like, but how would you work with that? I mean,
I can honestly tell you that I can't, even in my worst nightmares of laying awake at night. Right now, I'm short in next week's schedule 2,325 hours of direct support. If they lower our rates, those folks might as well be on the State House lawn.
thank you. So this 642 would advance your position in dealing with access to care and workforce challenges across the state, okay? And then, so yeah, it would do that. And then hopefully what these rate studies will do is show us that we need to hold that in place, because that's really where it should be. That's what I'm
Absolutely.
hearing from you, correct?
Yes, absolutely.
Thank you.
Any other questions? Seeing none, thank you.
Thank you.
Karen Rosenberg?
Good morning. My name is Karen Rosenberg. I'm the Policy Director at the Disability Rights Center of New Hampshire. And we're in support of this bill, but also think it needs an amendment. And so I want to explain to you the amendment that we think is required, as well as why we support it. So what's being distributed is a portion of 171A1. This is the beginning of our developmental services statute. And it's the only place that the term waitlist appears in that statute. It's, and what I've done is, basically you'll notice the only place that the term waitlist appears is in the title, which has no really legally enforceable, it's not legally enforceable. What's enforceable in our law is what's in the body of our laws, you all know. And basically what happened in 2007, there was a law passed that eliminated waitlists and required the department to request what it needed to fully serve people who have developmental disabilities or acquired brain injuries. So what didn't change were the department's rules necessarily, or their computer database that they use when they interface with the area agencies. So what's problematic about this bill as passed by the House is that it seems to incorporate a term, waitlist or waitlist registry, that is prohibited under current law. So I think that is the whole issue with waitlist. We should not at this point be changing our law to say, okay, you can have waitlists. What's good about 642 and what's helpful is that it seeks to resolve a problem or address a problem that people are experiencing now. We hear all the time from people who are unable to get out into the community, who are basically isolated in their homes or residential settings because they are unable to hire workers that they need, or get the vendors in place to get them out into the community to actually implement their service plans. So we're talking about things like being able to do volunteer work in the community, or get training to be able to seek some employment, or even to be able to enjoy recreational activities in the community. And while we understand that the department is in the process of addressing rates and that this may ultimately be resolved, people are hurting now and have been for a really long time. And so this is a temporary measure. Perhaps it doesn't need to be extended, through 2 bienniums from now, but it is something that would be really a meaningful change for people who are in this situation where their needs haven't changed. So they're not entitled to a change in their budget under a current law, But what has changed is their ability to hire the staff or contract with the vendor agencies to meet those needs. So for that reason, I would recommend that this be passed, but with an amendment. And I've already been in touch with the department and with CISNY and the area agencies, and it's something I think we could work on.
Senator Abar?
So you don't have an amendment ready for us, or?
Well, I thought I did, except that I've started talking to other people about it, and I think it needs a little tweaking. So I think that we just need a little time to work on it.
That's my question.
Any other questions from the committee? Seeing none? Thank you.
Thank you.
Jennifer Bertrand? Welcome.
Good morning. Good morning, Senator Birdsell and members of the Senate Health and Human Services Committee. My name is Jennifer Bertrand, and I live in Mount Vernon, New Hampshire. I'm here to testify on behalf of myself and my family. I'm asking the committee to support 642, HB 642 as amended. I know that after speaking with Karen from the DRC, like Rebecca mentioned, certainly I will leave the use of the word waitlist to the minds of the lawyers, and certainly would be amenable if there's another way to phrase that. Obviously, you've heard today that this bill creates a mechanism for legacy budgets, DD budgets, developmental disability budgets that are 24 months or older to be considered for a cost of living increase if the funds are available. It's important, I know we're using the word waitlist and there might be some more discussion around that, but it's important for us to keep track of how many people are we talking about and how, what would be the cost of providing those cost of living increases in order for folks to be served in the community. Keep them out of more segregated placements like a nursing home or an institution. I'm a devoted parent, and my adult daughter, Chloe, experiences a significant intellectual and developmental disability. She served on the DD waiver, and she has a great life right now. It's come at a cost to our family. We live every day in fear of losing the workers we do have. We haven't been able to fully staff her for more than 3 years, but during the course of the pandemic, I don't have a full-time worker. My husband and I are very fortunate that we can work remotely. He's with my daughter right now, and we swap care every day. After she goes to bed at night, we're finishing up our professional work and, working full-time, providing care 24/7. She has some significant support needs and a serious seizure disorder as well that has worsened over the last 3 years. It's exhausting, and I don't know how long we can sustain this. And I know there are a lot of other families in our situation. And addressing the workforce crisis, I know that there are a lot of big issues before you and before the budget as well this year about how do we address those workforce issues even in hospitals and nursing homes. These families, these individuals will be there, or we'll be sending them out of state if we don't address this. This is the most cost-effective way to serve people. With our help, Chloe has opened her own little business. It's a data destruction enterprise, Chloe Shred Shed. I'm sure she's out in the shred shed right now with Sean, shredding to her heart's content. It's something she feels very passionate about, and it's a valuable service, and she's able to work as much as she can and support some of the needs that she has. But because of the nature of her developmental disability, she requires 24/7 support. She can never be left alone. I'm 52 now. My husband turned 53. Our older children, one's married, one's in school, and we were looking forward to enjoying our life. At the end of the day, I don't sit down on the couch and put my feet up because Chloe's needs are ever present, and she literally cannot be left unattended. I know that we heard some opposition about the bill from the department. Despite previous rate increases, this need has not been met for years and years and years. And I know at the House hearing, we heard that there were some folks that more than 10 years have not received any kind of a budget increase. The only way you can increase the wage of your DSP is if the family chooses to have fewer hours of services. So parents and caregivers are taking on more and more in order to be able to pass any kind of increase and keep the workers that they do have. And it takes a special kind of person who wants to assist your family member with these activities of daily living. Chloe has some significant communication challenges. They're complex. We need skilled people that can support her communication so she doesn't use behavior to communicate, so she's safe and that people around her are safe. And we want her to continue to be productive and to work. I know that there's this BDS system work going on. We heard about it from the previous testimony. But there is no guarantee that the rate work is going to increase budgets. And we've seen this historically. Just see if there was anything else. The unintended consequence of not acting and not passing this bill is risking someone like Chloe. And I promised her, like, over my dead body, I will not put you in a nursing home or place you somewhere in an institution. But, you know, if something happened to my husband, I could not do this on my own. And I already know of a lot of parents who are single parents because maybe the stress and strain of supporting a loved one with a disability can sometimes impact your marriage. What happens to those households where there's a mom or just one dad who they have to choose between working or placing their child somewhere, and it's going to cost the state more money. We're partners as parents. We're willing to put in the work. We get up 2 to 3 times every night for Chloe to resettle her and make sure she's safe. That is unpaid time. We contribute in so many other ways with transportation and other things because Medicaid only covers the basic bottom minimum. So I urge you to pass this bill. It's long overdue and it's needed, and we must do it now. Questions?
Thank you, Jennifer. Any questions?
Thank
Senator
you.
Whitley.
Thank you, Madam Chair. I just want to thank you for coming and, you know, describing what it's really like in New Hampshire. I think that perspective is so important for us to hear about, you know, your efforts. I've known Chloe for since she was a little girl, and I hope that you give her my best.
Well,
Thank you.
Any other questions from the committee? Thank you. William Walker. Welcome.
Thank you, Chairman and members of the committee. My name is William Walker. I live in Hollis, New Hampshire with my wife and my 24-year-old son who has autism. I'm here to request your support for HB 642. What I believe it will do is help us retain our most skilled and important workers. I think the existing system encourages them to leave. Okay, and so where are we right now? Right now, my family's in a very good spot. We have a service plan that we developed with our area agency. We have a direct support professional that brings my son to his job at Meals on Wheels. He does volunteering in the community, and she continues to help him with independent living skills, and you know, just has a good life. Okay, but how did we get here? It took a long time. It took about 6 to 8 months before we were able to get to this spot. What does that involve? It involves the development of a service plan with our area agency. We develop this plan, we get a budget. This budget, basically take it, define the budget, tape it up, and put it away. Okay, then we have to go as family members, recruit and hire a direct support professional to work with our son. With the workforce shortage we have right now, it takes a very long time. It took us about 6 to 8 months. And during that time, once we hire somebody, we're lucky, they then develop a rapport with our son, and it takes the time for that to get going. So what we're looking at is 6 to 8 months, maybe even a year of time where my wife and I have to provide 24/7 coverage for our son. And our ability to have a regular job is put at risk. And at the same time, our son does not receive services. Okay, so this is a very bad position. So we're very lucky right now. Molly is his DSP. She is fabulous. She helps him a lot. If we fast forward with this folder that's been taped shut and the budget remains flat, SB 86 and HB 2 are not going to address that. The budget stays flat because his service plan didn't change. Okay, so what we risk is further into the future, 2 years into the future, the cost of living has gone up. The rates remain flat. And that encourages somebody with 2 years of experience to leave because they need to have a gainful employment. They need to have a cost of living. Okay, so what this bill would do is allow that to open up and allow the wages for our DSP and the service coordinators to track the cost of living. Okay, the way we have to do it right now was explained earlier. While we have to go through an exception process, and the exception process is not guaranteed, and therefore, you know, it's not even at the highest priority. It's not guaranteed. So really, what we're looking at is the risk of losing our DSP. The other thing I would like to talk about is I came from high tech, so I was in 30-some years in high tech. There was something called Error 33. Okay, Error 33 was predicating your success upon the success of somebody else. Okay, so what I see here, and I've committed Error 33. Okay, so what I see here is classic Error 33 inclination, saying, well, we got this BDS systems change that's in flight. Let's just depend upon that thing succeeding. Okay, and I am not just speaking from an outsider point of view. I am on the advisory committee and the rates working group for the BDS systems change. So I see where things are. Everybody's working very hard. I believe their hearts are in the right spot, but the thing is going to take a long time to get right. And you commit Error 33 by depending upon that succeeding in order to unleash the wages for people on DSPs. So I urge you to not commit Error 33 here and depend upon the systems change. And I also urge you to please support HB 642, to support Molly, support Christy Dawn at Gateways, and support my son Liam.
Thank you. Any questions from the committee? Seeing none.
Thank you for your time.
Alex? We have Alex, and then we have one last speaker on this bill.
Good morning, Madam Chair and members of the committee. I'm Alex Katrubis. I'm here representing the 10 area agencies that provide and coordinate services for people with developmental disabilities and acquired brain disorders. We support this legislation. As you heard from Representative Stringham, it passed 20-0 in the Health and Human Services and Elderly Affairs Committee. At that public hearing, the department was neutral, so I'm not sure what changed between crossover, but they were technically had no position at the House public hearing. And as you've heard, this bill is aimed to help individuals who entered the DD system years ago, but whose needs have not changed very much, if at all. And we feel that this bill is needed because of the difficulties the area agencies have had when they've tried to increase an individual's budget. That no longer reflects the current fiscal realities and the employment market that we're facing today. And by continuing down the current path, we really feel that we're putting services at risk. And as you've heard, under the current law, an individual's budget cannot change without a significant life change. So that means budgets that are 10, 15, 20 years old sit there under the current rates, and we have dollars that are available. You heard from Senator Rosenwald on the Senate floor, $80 million is going to carry forward for developmental services. So we have, I talked to an area agency last week. They have a budget that was approved in 2003. It's $12 an hour for the DSP. We've got $80 million in a savings account or a checking account. We've got a $12 wage that was set 20 years ago. And we can't, all this is trying to do is give DHHS a tool to move even a portion of those dollars. Even if it was 10%, 5%, 20%, it gives them a tool to use the resources that you've provided them in the budget and moves it to where it can, where I don't think anyone would argue that is needed. And certainly when you have a budget, an individual who's been in the system since 2003, he has a program, it's working well. He or she has a program, it's working well, but their needs haven't changed. They've been consistent, but we can't continue to rely on this, especially when there's dollars available. So there's no appropriation in this bill. It just says, can we use the funds that are there more effectively? That's really all this does. It gives, if you read the bill, it gives the department the authority. And if they don't believe that the current funding can support increasing these budgets, then they don't approve it. The issue with the waiting list component, the reason that was put in the bill was for those budgets that aren't approved by the department, we just wanted a mechanism to keep track of those that aren't approved so we understand how many we're talking about and what the need is. Certainly, we're willing to work with the DRC if there's another term. Some people use projected service needs list. It doesn't need to be the term wait list. So I'm certainly open to working with Karen from the DRC on some language for an amendment. Certainly willing to work with Melissa on any concerns that they have. But again, a lot of this was news to me this morning. In terms of the corrective action plan, we all know that July 1st is the current target date for conflict-free and direct bill. The rate review is part of the redesign, but it is a separate component. It's not required by CMS as direct bill and conflict-free are. It's an elective process that we're undertaking. You as the Health and Human Services Committee, and I mean no disrespect to the department, but how many times have we heard things are going to go live? How long has it taken to get adult dental solved? Medicaid managed care, all of these deadlines get pushed on and on. It's because they're under the same pressures that providers are under. So I see this as a bridge to the new payment model. I really do. If we need to move the sunset a little closer, it's 2027 is too far away. Certainly, if we move to the new payment model and that solves this issue, I'll be here supporting a repeal or a change in what we're trying to do today. But really, this is we looked at the budgets. We have these older budgets. We have $10, $12, $13 wages. We can't hire staff. We've got $80 million. Can't we move some of that? Surely we can afford to move a percentage of that to these older budgets so that we don't put services further at risk. So that's really all this is attempting to do. Can we use the existing dollars more effectively? Give DHHS a tool to better implement the budget. That's all this is trying to do.
Thank you. And Alex, I will take you up on if you would work with Karen and Melissa to try and put together an amendment, that would be great.
Absolutely. I will definitely commit to speaking with them.
Any questions from the committee?
I appreciate it. Thank you all.
See none? Thank you. Our last speaker is Karen Blake. Thank you for your patience.
Thank you, Madam Chair and members of the committee. I should have let Alex close us out. My name is Karen Blake, and I live in North Woodstock, New Hampshire. And in full disclosure, I am the Director of Public Policy for CSNI, but today I am testifying on my own behalf. I am in support of HB 642. As everyone before me had talked about, this is really addressing a very important issue. One thing that I did want to just highlight a little bit more, I know that we're talking about, maybe changing the language a little bit, for waitlist registry, but to kind of think about, that there are categories currently for increasing a budget. There's, someone new to the adult system. There's someone new to the state or has become known to the department. And then there's a significant life change. But as the people previous to me have also talked about, there isn't currently a way to look at cost of living. And, so what I'm kind of envisioning is that there'll be another category that'll be added to this for however long that it's needed. And, to think about that, individuals who come in or have had a budget, they've effectively been living on a fixed income. And, you may want to think about, why is this important to me? Well, I have a 16-year-old son who experiences a developmental disability. We are in the throes of looking at transition. He would be one of these people that would get a budget and then stay on that budget for any amount of time. And, as a now single parent with the passing of my husband, this is really important to me, that to make sure that there is going to be a mechanism for him going forward, to make sure that he's going to get the services that he needs, because, I'm also 52, and, looking ahead for this young man, to make sure that he gets everything he needs going forward. So I would, in closing, I would like to thank you again for this opportunity to speak, and I would ask you to support HB 642 after they work on it a little bit.
Thank you, Karen. Any questions from the committee?
Thank you all.
Seeing none. Is there anyone here that would like to speak on House Bill 642, that was not given the opportunity? With that, I will close the hearing, and we will not, obviously not exec this today.
How's things in Dover?
Without ever seeing her.
All right, I will open the hearing on House Bill 217, and I invite the prime sponsor, Representative Schmidt, establishing a committee to study the effects of fluoride on fetuses and children. Welcome.
Thank you, Madam Chair. Nice to see those of you who are on Jelcar with me that were not in Jelcar today. I've served on Jelcar for a long time, so I'm a willing victim, but it's not an exciting committee mostly. Anyway, thank you very much for the opportunity to speak before you today to introduce House Bill 217. Let me just say by way of introduction that I'm not a new arrival to the subject of fluoride and its potential harms and benefits in the care of teeth and prevention of cavities. I fully accept that topical application of fluoride by a dentist or very careful use of fluoride toothpaste does work against development of cavities. But that's not the main use of fluoride in the state of New Hampshire at this time, or not the only main use anyway. And I've actually been studying this subject for close to 20 years in my time in the legislature, doing a lot of reading, read books, and attended lectures and so forth. So it's not a new topic for me. And so I'm not here just carrying water for a particular ideology or whatever, but rather I'm coming specifically as a result of a couple of recent high-value NIH-funded studies that have been replicated in point of fact, which have revealed neurotoxicity in fetal brain development and resulting in lower IQ, and increased ADHD diagnosis, for example. So I feel that we really need to take a new look at fluoride use in New Hampshire, and that's the reason that I've offered this bill. Just for a little bit of reference, the House HHS committee has heard this bill, done a very thorough evaluation, voted 19-1 in favor of New Hampshire looking at these issues in a new light, and it also passed the House on the consent calendar. So there are witnesses here in support of this bill that you need to hear. So I will end my testimony. If there are any questions, I'll try to answer them. But otherwise, I want to let you hear from the experts. So thank you.
Thank you, Representative. Any questions from the committee? Seeing none. Representative McGuire.
Thank you, Madam Chair, members of the committee. For the record, my name is Dan McGuire. I represent the town of Epsom. This bill wasn't on my radar until this morning when I was seeing my dentist, and he mentioned the bill to me. And so I wanted to come and talk about it slightly. So I am strongly, based on my experience and my observations, I'm strongly pro the use of fluoride in children. And to the extent that this bill is perceived as somehow anti-fluoride, I would be against it. But if the consequences of this bill might be greater use of fluoride or more use in children, then I would be in favor of it. So I'm essentially neutral. So let's talk about experience and observation. So personally, I spent roughly half my childhood on the East Coast and half on the West Coast. And when I was on the East Coast and my adult teeth were developing, my mother, fortunately for me, gave me fluoride pills. And as a consequence, my teeth have been very, very good throughout my life. By comparison to Carol, who grew up in Connecticut without fluoride, she's had much more problems with her teeth than I have. And I have very few cavities, very few crowns, all this sort of stuff by comparison. So just from personal experience, I'm very pro fluoride. But then observation. So I've lived both on the East and the West Coast. And on the West Coast, there's much more naturally occurring fluoride in the water than there is here. And it's just, it's inescapable that you just see the teeth of people here are in much worse shape. There's a lot more missing teeth and that sort of thing than you see when you live on the West Coast. It's unavoidable. So I think fluoride is a good thing. And if this bill could show that and make people aware, that would be a good thing. If it's the opposite, then the opposite. Thank you, Madam Chair.
Thank you, Representative. Any questions from the committee? Seeing none. Thank you. Chris Neurath.
Hello, my name is Chris Neurath. I'm the research director of the American Environmental Health Studies Project, and I'm speaking in support of HB 217. Just last month, the National Toxicology Program, or NTP, released a final version of its systematic review of fluoride neurotoxicity. Their report includes detailed information and evaluations of the over 150 published human studies on fluoride neurotoxicity. The NTP report will be an excellent source of information for the study committee. Some dental groups are upset at its findings and have tried to dismiss it. I recommend you read it for yourselves and come to your own conclusions. As examples of some of the recent high-quality studies, I've given you each a packet of the first pages of a half dozen of the most important studies finding harm. I'd be happy to provide the study committee complete copies of these or any other papers. You don't have to take my word for it that there's a substantial body of scientific evidence. 2 senior editors of the Journal of the American Medical Association posted comments when they published just one of the studies. They said, and I'm going to quote them, Dr. Rivara. The paper is about fluoride and maternal fluoride exposure during pregnancy and its effects upon IQ scores of children at ages 3 and 4, which in itself is like a shocking title because I had never known that there was even any concern that maternal fluoride use might affect children's IQ. Dr. Christakis, the traditional teaching when I was going through residency in my early professional career was that fluoride was completely safe. All these people that are trying to take it out of the water are nuts. It's the best thing that's ever happened for children's dental health, and we just need to push back and get it into every water system. So when I first saw this title, my initial inclination was, what the hell? Dr. Rivara. A 1 milligram per liter increase in the maternal urinary fluoride concentration was associated with a 5-point lower score on the boy's IQ. Christakis. Right, an effect size which is sizable, on a par with lead. Right, it is. The effect size is really quite large. The results are really startling. There have been other observational studies that have shown this, and there have been animal models as well that have shown this idea that fluoride could be a neurotoxin, which again was totally news to me because I thought it was junk science. Anyone would ever say such a thing. Dr. Rivara. So if mothers now come into their doctor's offices and ask the pediatrician what to do, what are you going to say? Dr. Christakis. I think I would advise them to drink bottled water or filtered water. Thank you. And I'd be happy to answer any questions you might have.
Thank you. Any questions from the committee? Seeing none.
Thank you.
Gail T. Brown.
Taking us in a different order. Is this okay? My name is Gail Brown, and I'm the director at the New Hampshire Oral Health Coalition. And I'm here today on behalf of the coalition to ask, we oppose this bill, and we ask you to consider finding it inexpedient to legislate. I'm going to talk a little bit about who we are, but just very briefly, as many of you know us. The New Hampshire Oral Health Coalition has been in New Hampshire 20 years. And if you look to the right of your sheets, you'll see who's on our steering committee and what groups they belong to. So as an organization, we are representing dentists through their professional association, through their practices, through their community health centers, the medical society, the pediatric societies in New Hampshire, community health centers. So as many of you know, the more people you get together, the more fun finding agreement can be. And we are here today in agreement. I will say I tried to send this to you last night, and you may have received, oh, you did. I was going to apologize. You had either 0 copies or 5. I wasn't sure. Okay, down to business. We, as a coalition, we very strongly support evidence-based medical and dental care. And I'm here today not to talk about the science of fluoride. I am not a scientist. I'm here today to talk about the purpose of this bill, which is to formulate a committee. Currently, the related studies and the literature that is being reviewed, as noted by the doctor previously, and that is coming out, and as he reported, as the report has come out, that report actually has been blocked and is currently been pulled back to be able to be looked at by a group of 10 scientists, all at the doctoral level, either practitioners or researchers, and they will be submitting or submitting, I guess, a report on May the 4th that will be available to the public so that we can understand, number one, what's in that report that was discussed, what the findings of it were, why it was held back, and how it is now supporting its new conclusions. And as everyone has said, we don't know what those conclusions are going to be. So we have a couple of key considerations that we'd just like you to consider, again, looking at the building of the committee. The scope and charter of this proposed committee is really very highly focused, and the proposed work requires a very strong understanding of clinical chemical science, and the knowledge of research and data methods. That's why it's being looked at by the groups that are mentioned, and I put their names at the top. I know that you have the report. It was submitted by Northeast Delta Dental. I didn't want to give you another 6-page addendum because you do have the information. This defined work is hard. It is very broad, and as fluoride has many, multiple applications in both dental and in medical. We're not just talking about, you've heard about community water fluoride, you've heard about topical fluoride. That's not what this bill is calling to have happen. It's looking at a very broad analysis. So what we wonder, how will the legislative committees be selected that will be looking at this topic? Are they scientists in nature? Even this particular NASM group is having some disagreement amongst them, and they are scientists in nature. Are our legislators, this is defined as totally legislative at this point, are our legislators going to understand the difference between primary peer-reviewed studies on fluoride children and fetuses? Are they going to understand how that is different from any peer-reviewed dose, response, or benchmark? I don't. And for the purpose of this committee, I'm not going to be putting that work together. I'm going to be depending on professionals that are able to do that. I'm waiting for the NASM report. So just a couple of other things. I think you understand what the underlying piece of our testimony is here today. We do leave that to the experts. We look out to the American Dental Society, the American Medical Society, the American College of Obstetricians and Gynecologists. Trust me, they work very hard on this issue. Medical Society, Pediatrics, General Dentistry, and on and on and on. It is the purpose of those scientifically trained people to take the information that it will be coming from NASM and other reports and figure out how that applies to their practice. It is not my ability. So one of the things that we are concerned about, and this was brought up in the House, I think this is very important. We were several folks were asked, some of them in this room, well, what are you afraid of? Are you afraid of something that's going to come out in the report? Otherwise, why don't we have a study committee and come up with what the answer is? And that was addressed by Representative McGuire this morning. I agree exactly with what he said. You know, we might find something good, we might find something bad, we might find something in between. That is all true. However, it's not that we are afraid. It is that we are concerned about the amount of resource time that this is going to pull together, because when you have a 5-person committee, you pull all of these people into following where you're going, what are you doing, do we need to, that's our job. Our job is to bring you information, the latest, greatest, and help you have that debate. This committee would require a lot of that time because we're looking at needing dentists, physicians, and all these other program directors, DHHS, et cetera, to come every time we do this. So our question that comes back to you is it worth, is what this committee can present back, is it the right forum? Is it going to be more important than what we read from those who are scientists? And can we afford the cost? I'm going to give you a very specific example. Alex, earlier in his testimony on the last bill, he talked about how long it took to get adult dental in place. The answer's 20 years. If you want to know how long Senator Bradley worked on it, probably intensely for 6 to 7 years, and we appreciate all of this. But what's important now, if you read the news stories, Keene Sentinel, saw NHPR, saw other stories this weekend, you know that bill's in place. It launched April 1, and Delta Dental had vans and patients served with dignity in 2 parts of the state. But you know who needed to be in the front line to serve them? Our dentists. And if you saw the story this weekend, you know we don't have enough dentist capacity right now to be able to serve those patients. I ask you please not to I ask you, I guess, to really consider the purpose, the intent, and potential impact of this bill, because it's going to be very costly to pull our practitioners and program managers away from the work we need them to do. Thank you. And I'm certainly open to questions. Don't ask me about the science, though.
Thank you, Gail. Any questions from the committee? Seeing none.
Thank you.
Oops.
I
Okay.
usually get to wrap up, so I'm kind of excited to be.
Katie LaJoy. Welcome.
Thank you. Good morning. My name's Katie LaJoy. I'm a nurse and I live in Charlestown. I'm here today to support this bill. New Hampshire law currently allows for the addition of fluoridation chemicals to the public water supplies in about a dozen communities in our state. The legislature, however, has not independently looked at the latest science. And that's what we want you to look at, is the latest science on how fluoridation of water, fluoride may be affecting our children, health of citizens. I support the fact-finding mission because according to some researchers, the debate on the fluoridation of drinking water has been reignited as new studies find that fluoride is toxic to the developing brain. This is incredibly serious stuff. I'm here today as a private citizen, but for many years I worked as a nurse in the childhood lead poisoning prevention program. So I understand about neurotoxicity. And in the United States, there was a big pushback on dealing with lead poisoning and lead-based paint. There were organized efforts to fight bans, restrictions, warnings on lead-based paint. It was marketed as being safe, lead-based paint. With regard to water fluoridation, we must avoid the nature and extent of the denial seen in the past with childhood lead poisoning. We really need to come to grips with this. Mounting evidence suggests fluoride may be hampering brain development and reducing kids' IQs. We need to rethink exposure for pregnant women and children. And I am going to email you links to some studies, and they've been alluded to by Mr. Neurath. One of them came out in the Journal of the American Medical Association, a very reputable journal, found that fluoride exposure during pregnancy may be associated with adverse effects on child intellectual development. 3 of the authors said that the study is consistent with other high-quality research. It's not a standalone study. More than 50 studies have shown an association between higher fluoride exposure and lower IQ. Another study by Bashas found IQ decrements in children exposed to fluoride in utero. Another one by Riddell found that higher tap water fluoride levels and fluoridation of municipal water supplies were associated with higher risk of an ADHD diagnosis. And they talked about cumulative impacts of fluoride exposure. Another study found exposure to increasing levels of fluoride in tap water was associated with diminished nonverbal intellectual abilities. Another study from public health nursing talked about the mounting evidence showing the potential harms of exposure to fluoride, including low IQ, neurobehavioral deficits, endocrine dysfunction. A recent study found fluoride in drinking water associated with increased risk of hypothyroidism in pregnant women, and thyroid disruption may contribute to developmental neurotoxicity. And there's also reports of a consistent inverse association between fluoride exposure and children's IQ. And this was from the Fluoride Action Network, and they were citing the National Toxicology Program's systematic review of fluoride exposure and neurodevelopmental and cognitive health effects. A researcher, Dr. Christine Till, said there's mounting scientific evidence showing a consistent pattern of lower IQ associated with early life exposure to fluoride. She wants to know how much more information is needed before we raise concern. The failure to act could amount to enormous costs at the population level. Your support for HB 217 will help increase our understanding of fluoride's risk to the developing brain and will inform policies going forward regarding dental care for our children. So all we're asking for is that you look at the new science. It's very important. Thank you very much.
Thank you, Katie. Any questions from the committee? Seeing none.
Thank you.
Michael Auerbach. Welcome.
Thank you, Madam Chair. Thank you, Madam Chair, and through you to the members of this committee. For the record, my name is Michael Auerbach. I'm the Executive Director of the New Hampshire Dental Society. On behalf of our nearly 1,100 member dentists, hygienists, assistants, and office staff, I'm speaking to you today in opposition to HB 217. This bill proposes establishing a study committee to assess the perceived negative impacts of fluoride on children and fetuses. The very nature of this charge is problematic, as it seeks to ask this legislature to carefully analyze and offer policy recommendations based on the outcomes of incomplete and flawed studies. Put simply, this bill's proponents would have the legislature use its valuable time, resources, and money to ask questions to which the answers have already been provided to the legislature many times over the last several years and continue to be provided currently. Legitimate scientific research, along with the verbal testimony provided by New Hampshire-based and national experts who have researched the health benefits and risks of fluoride and community water fluoridation in response to the failed 2021, 2018, and 2016 legislative attempts to ban community water fluoridation in New Hampshire, all offer the same conclusions. One, that the carefully calibrated addition of 0.7 parts per million to community water systems is safe and helps safeguard children's teeth from decay. And second, that the community water fluoridation compounds and systems used in New Hampshire water systems are well regulated and well maintained to ensure the health and safety of residents. I've already submitted to this committee a annotated bibliography, which you all have, that includes a number of recent studies that validate, through legitimate scientific study, these statements. In these studies, the conclusion was the same. There is consistent evidence that exposure to fluoridated water by young children was not negatively associated with child emotional, behavioral development, and cognitive executive functioning during their adolescent years. Even the NTP, which has been cited a number of times just now, the National Toxicology Program is just last month removed its hazard classification on fluoride. In New Hampshire, we leave the decision making regarding whether to fluoridate public water supplies to the voters at the municipal level. The proponents of this bill acknowledge this fact and seek passage of this bill because voters have overwhelmingly rejected their attempts to halt community water fluoridation in municipal elections. Residents in those cities and towns have by and large chosen not to revisit their community water fluoridation programs on the ballot because their children have experienced the health benefits of fluoridation, and none of the issues the bill's proponents claim are attributed to fluoridated water. This bill, put simply, is a solution to an issue no one in the affected communities is experiencing. The dental professionals who are part of the New Hampshire Dental Society community are united in support of community water fluoridation, as it is a safe means of protecting the oral health of our patients. There's no need for a study committee. With me today are two experts, and I encourage you to ask them your questions. These are dentists who have no financial or personal gain from telling you their opinions, which are based on scientific fact. The NHDS therefore respectfully asks that this committee rejects this legislation and vote it inexpedient to legislate. Thank you. I'll take your questions.
Thank you. Any questions from the committee? Seeing none.
Thank you.
Stuart Cooper.
Thank you, Madam Chair and members of the committee. I'm here to testify in support of this study bill. My name is Stuart Cooper. I live in Sutton, New Hampshire, and I'm the executive director of the Fluoride Action Network. We were founded in 2000. We're a New Hampshire-based group, and we are made up of 5,500 medical and scientific experts who are concerned about the overexposure to fluoride from any source. We support HB 217. This legislation, which has bipartisan support and sponsorship, will allow the legislature to review and discuss the dozens of U.S. government-funded studies recently published in leading peer-reviewed medical journals linking low-level fluoride exposure in North American communities to potential harm. Now, I want to clarify some stuff. First, this bill does not change fluoridation policy. Please read it. There's nothing to be concerned about. It's not pro or anti-fluoride. It doesn't require the legislators to take a position on fluoridation at all. They could come after this fact-finding mission and say, we support it, we endorse it, we don't find any safety concerns. So what we want to do is let you guys actually read the data. We're not trying to hide it from you. The study will inform legislators not only on fluoridation policy, but the policy that impacts those with naturally high levels of fluoride in their community. There are some, like Grantham, for instance, it's few in between, but Grantham is an example of naturally high fluoride levels. This will inform the legislature on that as well, and it'll give the study committee members an opportunity to ask questions of HHS and DEP about monitoring what are the fluorosis rates in New Hampshire. What are the mean urinary fluoride levels of pregnant women in Manchester? We can ask these questions. Next, the House Health Committee voted 19-1 in favor of this bill. I mean, some folks trying to make this sound more controversial than it is. The committee members asked opponents, why wouldn't you want legislators to review the science? We've heard that they believe you're incapable. I mean, you guys studied MTBE, PFOAs, BPA. You've studied lots of technical issues. It's a fact-finding mission. So I don't find that convincing. 2 physicians on the House Health Committee, Representatives David Nagel and William Potter, said at the public hearing that they did their own literature search because they were skeptical of the fluoride science. And quote unquote, they were shocked at what they found, published in leading medical and scientific journals. The bill passed on the consent calendar without objection, and I would urge you to do the same. The bill text requires, if you read it, that the study committee review only peer-reviewed research and government data. What's scary about that? I'm letting you guys have that access. I don't want to hide that from you or say that just ask me, trust me. I'm saying I trust you to read the data yourself. Those in favor of the bill, want you to see the studies for yourself. I want you to see the CDC's data on dental fluorosis. I want you to see the EPA's data on fluoride exposures to pregnant women in fluoridated communities. I want you to see the National Research Council's conclusions in 2008 on fluoride and potential harm. I want you to see the National Toxicology Program's review that they just put out a week ago. I don't know why somebody wouldn't want you to see that. You should be skeptical of those people. Now, the reason we need this now is because there's a large body of government-funded research indicating that fluoride is neurotoxic. Most of this has come out since 2017, which is why a lot of you haven't heard of it. Most of these studies have been funded by the National Institutes of Health. Of those studies funded by our government, 100% of them found harm. There was no wish-washy, it was completely consistent. That's why we're urging you to look at this. Just a month ago, a study NIH funded that was led by scientists in Toronto's York University linked fluoride exposure in fluoridated Canadian communities with a substantial increased risk of hypothyroidism in pregnant women. I've included that in the packet. A study from Canada published just this past summer in the journal Nutrients found that pregnant women who had low iodine levels, which is about 50% of women in America, and elevated fluoride in a fluoridated community, their son's IQ loss averaged 9 IQ points. That's the equivalent in peer-reviewed literature to a pregnant mother smoking 20 cigarettes a day for 9 months. Will actually reduce the IQ about 9 points. So that's what the studies are finding. I've included an op-ed in my packet to you from toxicologist Linda Birnbaum, who is the former director of the National Toxicology Program. She calls for policymakers like yourselves to please take notice, to research this subject, and to take action. And I'm also going to be sharing a video presentation from her after this. I'll send it via email. You can listen in her own words what she believes. The last time I was before this committee, was in 2012, and I brought to your attention that the dental fluorosis rates, according to the CDC, dental fluorosis is white and brown marking on the teeth. It's caused exclusively from consuming too much fluoride from age 0 to 8 years of age, and it's a biomarker of overexposure. We learned from the CDC in 2012 that the rate was 41% of our teens had dental fluorosis. You passed, as a result, a law warning children in fluoridated communities, their parents, not to reconstitute infant formula with fluoridated water. You can look at your water quality reports. The warning is there. You listened to us then. That rate, according to the CDC now, is 70% of our adolescents. We're overexposing them. This is CDC's own data. You took action before. I'd urge you to look at this, review the new data. And the other document I supplied to you was a brand new dose analysis conducted by Philippe Grandjean, who's well known for his work on PFOAs that New Hampshire listened to. And the benchmark dose analysis looks at what level starts to cause a negative consequence. And this is the first one ever done on fluoride and neurotoxicity. And it found that just a level of 0.2 parts per million, that's 3.5 times lower than what you find in a fluoridated community, will drop the IQ of a fetus, of a child, by 1 point. And so I've supplied that to you. I'm not afraid of you looking at it. I want you to read it. And according to the authors, let me just quote, given the ubiquity of fluoride exposure, the population impact of adverse effects from fluoride may be even greater than that from other toxic elements like lead, mercury, and arsenic. And the benchmark results should inspire a revision of water fluoride recommendations aimed at protecting pregnant women and young children. And one last thing, I just want to refute something that was brought up. You heard a second ago that the National Toxicology Program got rid of their hazard conclusion. This is why I want you to read this, because you'll see they didn't. Originally they had one monograph, one systematic review, and in the hazard conclusion for their draft was that fluoride is a presumed developmental neurotoxin. That's what the NTP concluded. The NASM said, okay, you can conclude that. That's controversial. So you need to provide more transparency. So they divided the document now, the monograph, into a state of the science report with all the science and just the studies, and a second meta-analysis that they're going to have peer-reviewed in a medical journal. In the meta-analysis is where the hazard conclusion has been put. It wasn't deleted. They created an entire meta-analysis around it. And let me read what it says. It says, the review considered all human studies of fluoride's effect on the developmental brain. Actually, here's the quote. I'll just read the quote. Our meta-analysis confirms results of previous meta-analyses and extends them by including newer, more precise studies. The data support a consistent inverse association between fluoride exposure and children's IQ. And the report was issued in 2 parts, the monograph meta-analysis. The meta-analysis found that 52 of 55 studies found lowered IQ with higher fluoride exposures, demonstrating remarkable consistency. Of the 19 studies rated highest quality, 18 found lowered IQ. They could not find a threshold of safety. The harm was linear from the moment that fetus is exposed to fluoride. So again, this creates a study committee. It doesn't force the committee to make a determination pro or con on fluoridation. I'd urge you to support just like the House did. Thank you.
Thank you. Any questions from the committee? Seeing none. We're on our last 2 speakers on this bill. Dr. Brenda Burkle. Welcome.
Hello. Thank you, Madam Chair and members of the committee. I am Dr. Brenda Burkle. I'm president of the New Hampshire Dental Society. We represent dentists, dental teams, and our patients. It's on behalf of the latter group, patients, like each of you, I assume, that I appear before you today in opposition to HB 217. The very nature of the bill's focus, seeking to validate an unfounded and widely disproven claim that fluoridated water causes neurologic and developmental issues, reveals proponents' endgame to move away from scientifically proven benefit of the public oral health. HB 217 would use state resources to study an issue which nearly every legitimate scientific and healthcare organization in the world has given careful analysis. In fact, the scientific analysis is constantly updated, resulting in the same conclusion. Properly administered community water fluoridation programs, such as those that we have in New Hampshire, do not correlate to neurological issues. Does the New Hampshire General Court need to put forth its own study? There has been vast amounts of research. Information is good. Preparing for this, I Googled, and I found a meta-analysis, which are the best type of study. It was published in 2021, a cross-sectional analysis that evaluated 4,024 studies. Of those, it found some of them didn't list fluoride levels to which people were exposed. It didn't meet scientific standards. Of the over 4,000 studies, it only thought 27 of them were valid. Of those 27, they offered the answer that this systemic review and meta-analysis gathered evidence showing that following the World Health Organization classification of low and high levels in drinking water, exposure to low/adequate water fluoride levels is not associated with any neurological damage, while exposure to high levels is. As a dentist and healthcare practitioner, I examine the latest data as it becomes available through evidence-based studies about the best ways to protect the oral and overall health of my patients. I and other dentists are committed to a strict code of ethics and professional conduct and the Hippocratic Oath. These demand that we dedicate our professional lives to safeguarding the health of our patients and to do them no harm. HB 217, however, encourages the embrace of misinformation, which would violate my ethical and professional codes. It's for these reasons that I stand with nearly 800 member dentists and hundreds more member dental hygienists and assistants in opposition to HB 217. On behalf of them and our patients, I ask that you vote this inexpedient to legislate. Thank you.
Thank you so much. Any questions from the committee? Seeing none.
Thank you. Oh, I do have a slightly condensed version of the meta-analysis.
Great. Thank you.
Thanks.
We'll make sure everyone gets a copy. Or Cam will make sure everyone gets a copy.
Thank you.
Dr. Lori Rogato? Rosada. Thank you. Welcome.
Thank you. Thank you, Madam Chair and members of the committee. My name is Lori Rosado. I'm a private practicing dentist here in Concord, New Hampshire. I also am the volunteer supervising dentist for 10 public schools in this area, and I'm the chair of Council of Governmental Affairs for the State Dental Society. I don't want to be repetitive in what everybody said. Of course, I support what my colleagues are saying, but what I do want to stress to you is my concern here is that we can create a public health care crisis for our children. Fluoride is unrefutably needed in the community water fluoridation method for the kids of our communities. I understand the things that have been refuted about fluoride, and what we mentioned in the last hearing at the House is that we have to leave this to the experts, and there are experts in this country, the CDC, the WHO, the ADA, there's over 10 organizations. And recently, one of the foundings that they've found, if you look at these studies that are for removing fluoride, specifically one that was mentioned just a few minutes ago about the one in Canada, these studies have falsities in them. And when these falsities are found, the study in Canada, they ask them for their research and they refuse to share it. That's not commonplace in science. When you find a discovery, you completely elaborate and share everything that you find. And they refuse to share parts of their study. That alone should tell someone that these aren't the studies we want to rely on. The studies that were done in China, Iran, and a few other countries, they put fluoride at the level of 11 point something, over 10 times the amount of what we would want in the water. So yes, they did find IQ issues in these children. Studies done in New Zealand. New Zealand did an incredible study. It was longitudinal, where they could take children under 5 years old and study them and then follow them when they're in their late 30s. They found no IQ differences in these children that received the fluoride. So it's unrefutable. The evidence against fluoride it's unrefutable that fluoride should be in the water. Evidence against fluoride has consistently been proven to have falsities in their research and studies. And that's what I want you guys to know. If you do put this to study, you have to know how to read the studies. You have to be willing to call and make the questions. And that's why we have people like the CDC and all these phenomenal government organizations. And just the fact that our national toxicology program has removed fluoride as a toxin should speak in and of itself. Any questions, everybody?
Any questions from the committee? Seeing none? Thank you.
Okay, thank you, and I hope that you vote to ITL this bill. Thank you.
We will not be executing it today, so with that, I will end the hearing on House Bill 217. And do we want to go into exec for 613?
Move executive session.
Senator Bradley moves exec, Senator Prentice seconds.
Move on to pass on possible 613.
Hold on. If you're all going to have a conversation, can you please take it outside? We're trying to exec a bill. Thank you. Representative, you can stay as long as you're not talking. All right, let's move on.
I move on to pass on 613.
Second. Okay, Senator Bradley moves off to pass on 6.
So I'd like to introduce Amendment 1279 and move on to pass on that. It aligns 613 with Medicaid expansion, so I think it was amply discussed.
All right, Senator Bradley moves Amendment 1279S. Senator Avard seconds. Any discussion? Seeing none. All in favor of Amendment 1279S, say aye.
Aye.
Opposed?
I'll move on to pass as amended.
Any discussion? All those in favor of ought to pass as amended, say aye.
Aye.
Opposed?
Move consent.
Same too. All those in favor of consent, say aye.
Aye.
Opposed? And I'll take it out.
Madam Chair, what about 342?
Was that the first one?
Lead, yeah.
Yeah, I'd like to hold off on that a little bit. I just, I don't think I have a problem with it, but I want to run something by.
Okay. So for people that we weren't going to
Right.
that bill.
Oh,
So,
okay.
Yeah, this was the only one that I thought we probably exactly. Just for an FYI, we only have 4 more bills from the House that we're going to be hearing. Next week. So within the next 2 weeks, we should be able to be done.
Wow.
I don't see any on tomorrow's. I didn't see any on tomorrow's House calendar. So.
Are we getting a lot less this year?
They retained a lot. So, you can plan on a busy fall in early January. So,
I'll also try not to assign bills to this committee, given that Regina and I are going to be inundated on finance. So that's why medical marijuana bills have gone elsewhere.
Okay.
Please say thank you.
Thank you.
He's looking for some love this morning.
Put you one of those little pans that you can go.
All right. Do I hear a motion to go out of exec?
Second.
All right. All in favor? Aye. Opposed?